Welcome to UOA On Demand. I'm Dr. Pavli Demian, one of the interventional physiatry physicians here at UOA. And with me tonight to discuss spinal cord stimulations are Dr. Robert Pannullo and Dr. Tony George. So tonight we want to discuss spinal cord stimulation and neuromodulation. Dr. Pannullo, tell us, what is spinal cord stimulation?
Well, I would first say that we first pick what patient would be an ideal patient for something of this subject matter. One would be a patient who has chronic sciatica. Another name for that would be chronic radiculopathy. A patient who has chronic peripheral neuropathy, or an unusual condition called complex regional pain syndrome. And this is not a first strike procedure. It's one that comes about when patients have had multiple procedures done beforehand, including spinal injections, maybe even spinal surgery, months of physical therapy, medications. And essentially, we're looking at what can we do here for this problem, this nerve problem? And essentially, we are taking what looks like a wire, placing it in the epidural space, and then threading that up to the level of the spinal cord, usually from about the 8th rib level to the 10th rib level. And essentially what this does is that it will shoot a wave of stimulation to the back part of the cord, which is called the dorsal column, and then essentially shutting off or interrupting the pain signal, the nerve pain signal from the legs to the spinal cord to the brain.
And Dr. George, can you let us know kind of if a patient was a candidate for this, what's the process that the patients would go?
So typically patients come in with back pain. They've either tried injections, epidural injections, nerve blocks, ablations, and I've even gone to the extent of having spine surgery to address their issue. And if they don't get relief and they still have this persisting nerve pain, then I typically see if I can still challenge my patient and say, can I give you some relief? Can I try to at least do one more epidural or try to do another transforaminal injection just to see if I can do one of two things. One, see if I can give them relief. Maybe some others have tried and may have failed. If I can give them some relief, or number two, if that's not achievable, at least to confirm that, yeah, it is coming from this persisting nerve pain that is going into the limb, and get that confirmed. Once I have achieved that, if I've diagnosed that yes, there is a specific nerve that's irritated, then I go ahead and schedule my patient for a spinal cord stim trial. Prior to scheduling the stim trial, there are a few other things we have to do. We have to also get a psych clearance. That is to ensure that we are truly selecting the right patient for this procedure, a patient that does not have any other psychiatric comorbidities, and because they may skew the outcome of the trial. So we want to make sure that the patient truly is a patient that has pain with a pain that is going into their limb. And we also get blood work and a chest X-ray, and we want to make sure that the patient, when we have selected them, don't have any other bleeding disorders or any other reasons why they may not be a good candidate for this procedure. So those are some of the preliminary steps that I do before I schedule my patient for a spinal cord stim trial.
And I'll add to that, sometimes patients who may not be even surgical candidates whatsoever, they may have seen one of our spine surgeons or may have had another surgery and are deemed patients that further surgery would not help. Those can be very good patients as well. Dr. Pannullo, what can patients expect on the day of their trial and in the week afterwards?
Well, as you had mentioned, the word trial is that there's a two-step process. There's a trial and there's a potential implant of the formal stimulator. On the trial is that we are essentially placing the lead, or I often with patients call it a wire, that is put into the epidural space and then brought to the therapeutic location. The trial lead is not secured in the back as would be the formal implant. Rather, it is secured externally with the leads attached to a battery, which is put in a pressure dressing in the back. And I like to use an abdominal binder to make sure that it's locked in place because we do not want what's called lead migration. And then typically over that following week, the patient is followed on a daily basis by the spinal cord stimulator representative. Different settings of the unit can be tried to make sure that to optimize the therapeutic effect of the stimulation. And then within a week, and I usually do not like to do more than 1 week, have that lead taken out, and then to reassess to see how much improvement was seen. And then from there, to have the patient then be considered for the formal or the permanent implant.
And Dr. George, when it comes to implant, who does the implant? And what are my options if I was a patient who had a successful trial?
So typically, the implant can be done by a spine surgeon or an interventional pain physician who is adept at doing these implants. And they can do it through one of two ways. One is using paddle leads, or one is using percutaneous leads. And that determination is made based on the patient's anatomy. Some patients have more of a challenging anatomy, and it may make more sense to refer that patient to a spine surgeon for them to do a paddle lead placement. And other patients may have a more favorable anatomy where it may make sense for them to do a percutaneous lead and subsequent implant.
Dr. Pannullo, I'll follow up with you. What makes a successful trial for a patient?
Typically, we're looking for a significant reduction in pain, so clearly better than 50%. And we're looking for functional improvement because over that trial week, I want my patients to be walking, to be doing things. Now, not anything to excess, but at least to try to engage in some normal activities, and then be able to assess how that has affected their life during that week, so as to then determine, is this something that they would want to have in them? Now, I would also add to it from a statement that was made before about a psychological evaluation. That's also required by insurance carriers. So that is something that to make sure that a patient is comfortable with having something implanted inside of them. And then I would also add is that during that trial week, we use antibiotic. I typically, I'm not going to use it during the week, but I do use it on call to the procedure room to make sure that there is no infection that could, so it's a prophylactic antibiotic. But the typical patient that we're looking to select is someone who clearly has chronic nerve pain that has been refractory to conservative management.
And I'll add to that. Again, I agree with everything you said, Dr. Pannullo. One of the things I'll add to that as well is sometimes some mechanical pain can respond to spinal cord stimulation, different types of neuromodulation. Dr. George, I've had patients who I've seen who've said, my friend has this company, my other friend has this company. They're both doing well. What's the difference between these companies? Can you help to kind of explain what each company, not specifically, but generally what each company does and what do they do different and what do they do the same?
They all have unique strengths, in my opinion. One is, and one company it may have a strength in addressing beyond the back and leg pain. It would be also to address the mood of the patient. It may help with the patient's affective issues as well, in addition to any of the limb pain. Another company, and now most companies even have this indication for back and leg pain. For the longest time, neuromodulation, at least spinal cord stimulation, was specifically to address refractory pain that was going to the limb even after surgery. But then over time, in the last decade, what we have seen is that neuromodulation can also help with low back pain in addition to limb pain. And now companies have, there's FDA approval to an indication for back and limb pain. So, and that is a new development, well, in the last 10 years. And more recently, we're also seeing spinal cord stimulation benefiting patients that have neuropathic pain, particularly pain from diabetes, peripheral neuropathy, where they've tried conservative management, they've tried medications, and that has not helped them, and they're having persisting neuropathic pain. And we know that neuromodulation is also helping with that. And that this is another company that has the indication, one of the three companies that I mentioned, which is approved to use that. So I look at what I look at my patient first, and I see what type of neuromodulation would benefit my patient the most, and then I decide to either go with the company A, company B, or company C.
I'd like to add to that as well. I think knowing what our doctors, Dr. Pannullo and Dr. George, use, in addition to myself, all the companies are long-standing companies that have excellent support and excellent customer service for the patients as well. Dr. Pannullo, what if someone has refractory arm pain as a result of their neck or nerve pain in the arms? Is there any options for them?
If I could just interject in regards to the previous subject, is that I think the important thing, and I mean this sincerely, I have no financial interest in any of these companies. So therefore, I agree with what Dr. George said in that we try to pick the best system for that patient. And that is totally patient-based, not about whether we favor one company over another, because we do not have financial interest in those companies. We have interest in helping our patients. And oftentimes one system may have something that the other one doesn't have that could benefit that patient. And I would answer your question in regards, so if a patient has arm pain, and this is, let's say it's a nerve pain coming from the neck, then a spinal cord stimulator can also be placed up in the cervical or neck region to help with nerve pain that has been refractory to conservative management, injection care, or even surgical care.
Thank you so much for that. To actually add to that, I know I've had in trials where a patient may not have been responding with one company. A lot of times the wires can be attached to a different company, and they each have their own proprietary waveforms. And we've been able to get good results with one company as compared to the others. And I thought that's been a really valuable tool for our patients. So thanks, Dr. Pannullo. Dr. George, concerning dorsal root ganglion stimulation, can you speak to that at all?
Sure. Dorsal root ganglion stimulation is a fairly new mode of stimulating a specific region of the close to adjacent to the spine, where dorsal root ganglion is, with a collection of nerves that sit in that region. And they did a study in the last 5 to 7 years where, for the longest time, the dorsal root ganglion was a unique and interesting structure that stuck around there. We found it interesting, but not a lot was pursued in trying to figure out what does it really do. We would sometimes do radiofrequency ablation where we do dorsal root ganglion stimulation, and there was some understanding that it could help with patients that had pain that was going into through specific nerve roots. But then in the last 7 years, there was a trial that was done by Dr. Tim Deere in West Virginia, who led that study, where they looked at stimulating the dorsal root ganglion. And what they found was stimulating the DRG, or in dorsal root ganglion short is called DRG, that patients that particularly had CRPS pain, compressed renal pain syndrome, which is a unique kind of pain, had a superior outcome compared to dorsal or spinal cord stimulation. And CRPS pain was for the longest time treated with spinal cord stimulation, but the DRG stimulation was superior to traditional spinal cord stimulation. And that opened a whole new window of opportunity to address a lot of patients that had complex regional pain syndrome affecting the limb, the foot. For example, many patients have had foot surgeries, and they end up having a painful limb from some either complications or whatever it may be, and these patients had to deal with this pain. But now with DRG stimulation, these patients were able to get relief. The process of doing DRG is very similar to doing the spinal cord stimulation, where you do a trial first. You see how they respond to the trial for that window of 7 to 10 days. And if they respond very well to it, you proceed by doing a DRG implant.
Dr. Pannullo, how would you kind of explain the process and the system of spinal cord stimulation to your patients who may be concerned about kind of having this implant in their body?
Well, one relatable or analogy would be that it's like a pacemaker for the back. As a pacemaker has wiring that is put into the heart, and that the battery is then placed into the chest wall. Here, this is the wiring that goes into the back, and the battery is placed in the either the lower lumbar region or in the upper buttock.
Thank you so much. Thank you so much, Dr. Pannullo. Thank you so much, Dr. George. And if you are having challenging pain, whether it be nerve pain, neck pain, or back pain, and think you may be a candidate, please reach out to us for this or any of your other orthopedic injury issues at uoanj.com.